Good evening, good afternoon, good morning, maybe. My name is Chris Bear. Welcome to the IOCDF Supporting Families live stream. This is our fourth in the series so far, and we are glad to have you with us tonight, wherever you are viewing from, whether it's live or on the replay. You can see in various comments wherever, if you're on Facebook or YouTube or Twitch or wherever this is being streamed to, share in the comments where you're listening in from or viewing in from. I'm here in Brooklyn, New York, and we have a great panel tonight, and so a great topic on treatment resistance and treatment refusal. And I want to introduce our guests tonight, and then we'll go over a little bit of a intro and particulars for this live stream, and then we'll get to your questions. So my name is Chris Bear. I've been the host here. I'm a parent of a teenager with OCD. I'm also the producer of Unstuck, an OCD kids movie, and I've been kind of active as the IOCDF advocate on the parent side for 9 or 10 years. Also have been the co-host of the OCD camp. So if you joined OCD camp last month, good to see you again. Natasha, thanks for joining us.
Yeah, thanks for having me. Natasha Daniels. Do you want me to introduce myself?
Yeah.
Move right into that. I'm Natasha Daniels. I am an anxiety and OCD child therapist, and I provide global resources for parents through a podcast, YouTube channel, courses, and books. And I also am a parent to 3 kids with anxiety and OCD.
Cool, welcome. And Dr. Jennifer Park, I'll just be calling you Jen the whole time, but thank you for joining us, and share a little bit about yourself.
Yeah, so my name is Jen Park. I am a licensed clinical psychologist, and I work with children, adolescents, and adults with OCD and anxiety and other disorders as well. Currently, I'm also working as the executive director of clinical services for California, Colorado, and our Illinois clinics for Rogers Behavioral Health. This is for partial hospitalization programs and intensive outpatient programs. So these are what we would consider higher levels of care. So our partial hospitalization programs are 6.5 hours a day, 5 days a week, and our intensive outpatient programs are 3 hours a day, 5 days a week. But we also have residential services for OCD and anxiety, both for adults as well as for children and adolescents.
Oh, great. I mean, we always get questions kind of about in-person treatment, hospitalization, how that works. So this is great to have you here. Very quickly, folks, before we get to the questions and tonight's topic, I just want to remind everyone this live stream is educational and not intended to replace therapy. For treatment-related questions, please work with your therapist or local provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The IOCDF has a great resource with lots of different therapists and options there. And the International OCD Foundation is not a crisis hotline. So if you are in a crisis or you ever feeling suicidal or unsafe, please dial 888 or 988, which is the Suicide and Crisis Hotline. So you just dial 988 from your phone. You can also access it online at 988lifeline.org, or you can go to your local emergency room, or you can always dial 911. So 988-911 or 988lifeline.org if you're feeling in crisis. And we want to keep this as a safe space, and so please be kind and respectful to each other in the comments. And at the end of the day, we're all here to support and learn from each other. So I just want to also remind everybody, since you're tuning in live, that this is being recorded and it is being broadcast on several social media platforms. Last but not least, we want to hear from you. So take the survey for parents and caregivers of people with OCD. There'll be a QR code coming up on the screen, or you can go to iocdf.org/parents-caregivers-survey. That's iocdf.org/parents-caregivers-survey. And you can give us valuable feedback that's going to help us not just inform future live streams that we run, but also programming across the board. And we also want to give a big shout out to Jack MHA, who is our sponsor, and Kim Vicente, who leads that organization. She was the brainchild behind having this live stream and this for families. So thank you, Kim, and thank you, Jack MHA, for their support, which makes this live stream possible. Okay, tonight we're going to be talking about resistance to treatment, some ideas, tools, tips, tricks to help children and kids of all ages and those with OCD to work through treatment refusal if they're having trouble working through therapy. And I, and would love your comments, and we'll try to get to as many as we can. But let's start with a basic question. So we know that kind of avoidance and working through OCD anxiety is something that is hard for everyone with OCD. So what are some of the things that a parent or a loved one might look to or look for to see if their loved one might be resisting treatment or might be kind of, shying back, or just, I don't know, things that somebody can look for to say, hey, maybe this is something I really need to pay attention to. I guess we'll start with you, Natasha.
Yeah, it could be a whole bunch of different things, but I think, one of them is when you bring up OCD, do they shut you down? Do they get defensive? So if you can't even talk about the topic, I think that's a really clear sign that there's a struggle or there's some sort of story or narrative they're telling themselves about it that is so they get defensive. Or if they get kind of aggressive when you're trying to get into therapy, or they tell you you're wasting your money, even if they're not aggressive overtly, you're wasting your money. I'm not going to talk, or they can't help me. These are all kind of indicators that there's some resistance there.
Yeah, I agree with Natasha. A lot of times, they might not outright say, no, I'm not going to, but they'll show up and they'll sit there and they'll say absolutely nothing, or they'll say, no, everything's absolutely fine. I don't really know what mom's talking about, or, what my husband's talking about. So there can be a bit of denial. And even when confronted by the situation, when they say, hey, these are the things that are happening in the home, they might come out and be like, nope, it's just a willfulness to even acknowledge the situation. But something that I like to remind a lot of the loved ones of folks with OCD is that just talking about OCD for a lot of people is an exposure in and of itself. So that, and for those who are pretty well versed in OCD, that's a huge part of our OCD treatment. And so it's really not uncommon for folks to not want to even broach these topics, to not even want to be able to say, like, I might have a problem or an issue, because to say it out loud for some may make it feel as though they're bringing it to life in some way, like they're making it real. And to say it out loud might then perpetuate, whatever feared result that they might be trying to avoid. So if I say it out loud, then it means it's real, and then all these horrible things are actually going to happen. And I like to remind families of that, to try to instill a little bit more patience and empathy into the situation, because usually by the time parents or loved ones may come to a professional for help in that way, it's after a lot of time trying to work with their loved ones, trying to get them in, trying to convince them to come in. And they've come by themselves because they're like very frustrated and they just don't know what to do. And it's like, okay, let's take a step back and think about what we're asking this person. What do they have to confront in order for them to agree to actually come in and get treatment themselves?
If you're working with somebody, so if we have that scenario where somebody might have taken a long time to come in, they finally agree, okay, I'm going to go into therapy, or I'm going to check out therapy and see what it's all about. As the therapist, do you approach somebody differently that way? Do you take more time, or do you just go straight into it, or how do you approach somebody if you kind of know a bit of a background that they're hesitant, or I don't know, maybe you just assume everybody is, so start the same way?
In general, I start the same way, unless it's made very clear to me that this person does not want to talk about it, and that has been taken a long time for this person to be able to come in. So in general, if that's not the case, I really try to meet the person where they're at. And I sort of shift how we approach talking about it depending on how the session goes and what they bring to the table at that time. So I try to normalize it, so talk about what we're going to be doing, talk about, these things that you might be experiencing. Before I even ask them, what are you experiencing? I'll tell them, here are some things that people experience. And again, just trying to be very, and for like a lot of the topics that might be related to things that they may feel shame around, or that they may feel are really, really hard to talk about. So things that may be sexual in nature, religious, aggressive, hostile, things like that. Just saying it out loud, because sometimes saying the words to them, they're like, oh, wow, she's saying it. Okay, so then if that's the case, then maybe what I'm experiencing isn't that odd. And then sometimes I'll even show them the Y box or the Psi box, the checklist. I said, do you want to see how common it is? This is what I use. This is how common it is. This is so whatever it is that you say to me, I've heard of it already. There's nothing you can say to me that will surprise me, even if it's not on this list. So being able to talk through it in that way really kind of helps set the tone to make the individual or the child in front of you just feel a little bit more comfortable. Now, if kids aren't even willing to kind of come in and talk about it, and I've gotten that sort of heads up from the parents, I might spend the first session just getting to know them, just kind of letting them know that this is a safe space, letting them know a little bit about myself, asking them about, what are their likes, their dislikes, what are the things that they want to do, what are their goals in life, before we start to broach the conversation of OCD and what that treatment is going to look like.
Yeah, I would jump in. I totally agree with all that. And sometimes I would say to kids when they first start, I would say, you're not going to hurt my feelings, but just tell me what you were expecting. What were you expecting? Or if they had seen multiple therapists before, I'll say, how did you like therapy? And it's not going to hurt my feelings, and then you get to understand what they were perceiving, and it's just, I've heard all sorts of things of what they thought we were going to do, or what I was going to do, or what I was going to be like. Thought you were going to be some little lady that's going to have me lay on a couch, like all sorts of weird things. But then you know where to start, because you're like, okay, this is your perception coming in, and now I know where you're coming from, and I can work with that and give you a different reality of what's actually going to be happening.
Yeah, everything that both of you said resonates with my experience with my daughter, where it's like building that trust, taking the time to make sure they understand that, like, this is the place, this is the safe space, I can hear everything, and that does build over time. And I imagine that, the majority of people don't just blurt out everything. They go, let's try this, let's see how she reacts to this, or they react to that. And welcome everyone. I noticed there's we have somebody from Australia here, Michigan, Wisconsin, Seattle, somebody else from New York, California. So this is great to see everyone. If you have a question about treatment refusal, or someone in your family that you love who might have OCD and is resisting treatment, please put that in the comments. We're happy to try to address as many as we can tonight. I just wanted to kind of building off the idea of somebody who's finally coming into treatment. Is there, on the clinical side, is there a special diagnosis or way, if somebody is resisting treatment, that you label them, or a way that that you have to take a different tact with them, or is it just something you feel over time that you realize?
Well, I'll talk a little bit about, in clinical settings, or, at Rogers Behavioral Health, because we get a lot of patients who come in with OCD and anxiety. Sometimes they might come in with, and depending on the notes and whatever sort of collateral we might receive from the referring provider or whoever they had been working with previously, they might have an indication in there that, this person has severe OCD with low insight, for example. And that doesn't necessarily talk about treatment motivation per se, but they are correlated in ways when there's low insight. One of the things that I think is so challenging about OCD is that, from a professional standpoint, we always talk about how it's an ego dystonic disorder, how it's something that's not aligned with what the individual wants and what the individual is experiencing. But we have these modifiers, if you will, where we do indicate from a clinical perspective how much insight do they have into their symptoms. So, do they have very good insight so they really know that, hey, this is not really something that I want to be doing. I want, it makes me super upset. Or are they folks who are saying, I have very low insight, not I have very low insight, but they've been identified as having very low insight, and they really don't see how they can distinguish themselves from their OCD. They can't separate themselves from that. And that can really, really impact treatment motivation. People with low insight can come in and say, you can't take this away because it's protecting me. And it's important that I continue to do these things. So that could be one way in which we might be able to identify. But of course, we have to do our own assessments. We really just kind of have to get a sense of what each person is willing to do. And my experience has been, I don't know until we get started with the exposures. Because I've also worked with some folks who are like, yes, here, and here's all the information. I'll answer all your questions. And then when we get to actually doing it, it's a lot harder, or it's a lot more challenging. And then the doing part gets really, really tough.
Yeah. Thank you for that. I mean, there's so much to unpack with each patient, and everyone's different, but to understand how you would approach somebody and identify them, and just kind of, I guess, helps move that along, and then let the loved one know as well how they could help. I have a question in the chat from SW. So loved one is seeing a therapist, but the therapist doesn't maybe not be the right one for I guess her loved one, because his condition is getting worse. This person has been seeing the therapist for 2 years and is unwilling to change to a new therapist. Any suggestions on how this loved one can approach it, or how you can, navigate that situation where somebody's seeing a therapist, maybe it's not the right one, and is unbudging to change? I don't know. Who wants to take that? I should hand out each question to Tasha.
Yeah, I think the first step is there really no change? Because that's an assumption. And so if you're able to, I don't know the loved one's age, but if you're able to meet with a therapist alone, if it's a minor, and say, I just want to get a perspective of what's been happening, because sometimes we might think that nothing has happened, but they would have been so much more acute if there hadn't been therapy. And so sometimes we don't know what's going on behind closed doors. Mm-hmm. And then if your loved one doesn't want to change therapists, depending on the child, depending on the age, if it's an adult, again, that's a totally different story than if it's a child. But I think every situation is different as far as, do I need to educate the therapist more, or give them more parental information if it's a parent, to help them? I know I've done that with my own son's therapy, and my own daughter's therapy, like, let me provide more information so there's more meat there, because the therapist doesn't know what the therapist doesn't know. And so there sounds like there could be some room for more collaboration. I just don't know.
I agree. It definitely depends on the situation, and also depends on what kind of therapist that they're seeing. There's so many different modalities of treatment that can be offered. So if there is a way for, like, especially if this is an adult child, if a parent can look into, to find out that, okay, what type of therapy does this particular therapist provide? If it's talk therapy, if it's, just different types of modalities that have not really been shown to be as effective for OCD. Is there a way in which we can either educate the loved one that has OCD to say, hey, are you doing these kinds of things in your treatment? Or even a way of saying, here's another person that you can see who specializes in this type of OCD ERP treatment, and you can continue to see this other person, because maybe that person is providing a lot of emotional support, but not really doing the specific treatment modality that's for OCD specifically. So just, kind of maybe, is there a way to kind of get the person in to the right person? If there is confirmation, in some way that maybe this individual or the person that they're seeing, is doing great work, but maybe just not in the realm of OCD.
Very true. And I like hearing the perspective that maybe it's okay to see two different therapists at the same time. I've always been curious, if somebody is an adult or over 18, how can a loved one get a, is a loved one legally allowed to talk to that therapist, or do they need permission from the person with OCD to talk to the therapist? Like, how any suggestion for how that communication might work if somebody is like when I was a parent, I could talk to the therapist. I mean, when I was a parent, when my child was younger, now that she's over 18, it's a little harder for me to say, hey, therapist, I want, let me tell you what's going on. So if they're not, yeah, sorry.
It's kind of nice if they're in a space where they're collaborative to get them to sign a release, so when they're like, when you have someone transferring over, in my practice, I would, when they were turning 18, I would be sure to have that paperwork signed, so that there was that continuity of care where that communication could still happen, because legally your hands are tied. If you don't have paperwork, now they're a legal adult, you can't communicate, and really having that dialogue is important. But some adult children may not want that, and so they may not sign that. They might welcome the privacy and confidentiality.
Yeah. And it's definitely more challenging with adults because of that, especially when you're working with adults where even as a therapist, you might say, man, I really wish I could get a little bit more information from the family to see how things are going in the home, or understanding the dynamics there. I know, people can message therapists, whatever they want. We just can't respond without a release of information. So as long as people can accept that they're never going to get a response, but the therapist may receive it, maybe they might block it, who knows? But we are able to loved ones are able to send those even without a release. They can call and they can leave messages even without a release. So there are ways to get messages through. However, the way that I would also handle that on the other end is that if I were to receive anything from a family member, I'd be sure to talk to whoever I'm working with. I'd say, hey, I want you to know that your mom, your dad, your brother, your wife, whoever did email me. And these were some of the things that they brought up. And I might even say, if it's very different from what we were working on, I might say, hey, can you tell me a little bit more about this? Where do you think they're coming from? And sometimes, their account may be very, very different. And I go with my patient. I go with the person that I'm working with, because I want to be able to meet them where they're at and really work on the things that they're willing to do. But also, in other times, it has opened up opportunities for me to encourage more collaboration, right? So, hey, your mom's writing me and saying these things, and we're working on this. Kind of sounds like we're not really on the same page about what is OCD. Do you think we can have one joint session together to talk about it? Maybe not a full release, because you'll be there, you'll be if you want, you'll be there in the session with us. We can talk about it together, so it's fully transparent, and we can prepare before your parent comes in, and we can process after they leave if needed. But I think sometimes it can be used as a tool to kind of have that invitation.
I want to move to another question that we have in the chat, and I think it's kind of around strategies and ideas of how to see if you can help somebody that who's resisting going to therapy, or might not be actively engaging in the therapy despite that they're going. We have Amy, who wrote in the chat that she has a college student who she was paying to go, and basically saying, each time you go to therapy, I'll bribe you to go to therapy with money. And she's clearly, it didn't work. And he just told the therapist, I'm only coming because I'm getting paid. So what are this kind of brings up the topic of what are some strategies that the loved one can actually try to, use, whether it's to a kid or a teenager, an adult, to, try to see that therapy can be useful, or get into therapy.
I think there's lots of different tools depending on the age of the child or the adult. And with adults, it gets a little bit trickier. But I would, in the beginning, we want to try to do a lot of positive reinforcement. How can we reward the behavior that we want to see? How can we encourage the person to go and to engage? But sometimes it's not enough, kind of like exactly what you're mentioning now. From a therapeutic standpoint, I would use, talk about values, maybe shift completely away from talking about OCD at all. What do you want in your life? Who do you want to be? Where do you want to be? What do you want your life to look like? And talk about that for a while before we start thinking, okay, so what's getting in the way of that? And allow the individual to come to their own conclusions about what they need to be working on. So sometimes when we have patients where the parents did their job because they were able to get them in the room, right? They did a lot by getting that person there. I think the other part is working with the therapist to try to get them to understand or to have insight into and motivation and to build that over time. Now it's not always, it's much more easily said than done to do that, of course. But there are different techniques and approaches that can support and help that. And with younger children, they are a little bit, I don't want to say easier, but we have a little bit more tangible tools, I feel, because especially when they're younger, you can reward them through tokens or the things that they are wanting for are a little bit easier. And it could be positive attention. It could be, one-on-one time with mom or some special time with dad. Just really kind of building out what is reinforcing for the child and really, really, really going heavy on the reinforcements whenever they approach treatment. So it's not, I always talk to parents where it's not about doing an exposure successfully or, doing everything perfectly right. It's just, are they showing a little bit of effort? Well, is that effort a little bit more than what it was last week or last month? Well, we should really be reinforcing that behavior. And so what is it that your child wants? And every single child is wildly different in terms of what they want. And so it's tailoring those reinforcers to that child.
Yeah, you talked about kind of like reinforcements, also like somebody who might be older or, maybe those reinforcements or rewards don't work, talking about their values, a value system. What do you want to get back? All useful kind of tactics for loved ones to try to help someone with OCD trying to start that treatment journey. We have a question from Lori saying her daughter doesn't think a therapist knows how to treat her exact issue. I think you might hear this a lot where, no one has what I have. And so that's the reason. When you have a patient that deals with that, any experience where that has come up and the patient's got the light bulb of like, oh, wow, I guess I actually do have she can treat me or strategies around how you might want to attach that, Natasha.
Yeah, normalizing is the first thing, because I think OCD is such an isolating disorder that people feel like no one has this flavor. And, I think we're trying to, as advocates, we're trying to disseminate more information. IOCDF is trying to get that message out that it comes in many flavors and disguises and it hops and morphs. But I think people get stuck on, well, I've got this taboo thought, or I've got this just right thing or disgusting, and no one's talking about that. They're just talking about hand washing. So having that loved one like watch a YouTube video, I'm big on like finding something that's related to that theme before they even get into the therapy office and say, watch this. Or if the parents give me a heads up, if it's a child, and they'll say, we're bringing them in, these are the symptoms they're showing, I will, as I'm developing rapport, I'll be like, OCD comes in many flavors. And then I will start to like outline an example that looks very similar to theirs. And they'll be like, I have seen that light bulb moment where they're like, their eyes are big and they're like, wait, people have that? People do that too? That's OCD? Oh, well, I actually have that. And so it's just so healing, I think, for them to not feel like they're alone. And you've got to get that, because there's kind of this defensive attitude of prove to me that you know what you're talking about before you can even get the door open. Yeah. And so you've got to show that proof before, there's going to be any buy-in.
Mm-hmm.
Yeah. Absolutely.
Sorry. I was just going to add on that, and this could be like great education for families too, to just be aware of, is that, the way that OCD is, it's not about the content. It's not about, what are the types of thoughts that I'm having? What are the types of behaviors that I'm doing? It's more of the function of the behavior itself, right? When I have thought, insert word here, then I feel anxious or upset or distressed. And then I do behavior, insert behavior here, and then it comes down, and I feel a little bit better. That's what OCD is. It's not just like you said, Natasha. It's not just the, oh, I feel dirty and now I'm washing my hands. It's anything. Just it's like a Mad Libs, if you will, just inserting the content doesn't matter. It's the function of the behavior and what that behavior does for the individual that makes it OCD.
Yeah, I think parents even get stuck on this, because I hear so many parents like me who will say, I want to take your course, but I don't know if you deal with contamination OCD, or I want to have your resources, but I don't think you deal with like moral OCD. And you're like, oh gosh, like it's important to know the many disguises because they do look different. So I think there is some benefit in saying, okay, these are the different types of themes, and it could be anything, but these are some common ones for the education piece. But then I think parents get into this like tunnel of, but do you treat contamination OCD? And then, and then you actually become your own barrier for your child's treatment, because now you're looking for this specialized treatment of, are they an expert in symmetry OCD? Because that's all
an expert within an expert, right?
Right.
Yeah.
Right.
Yeah.
Right. From my non-clinical point of view, it's like the job of the caregiver or loved one is, does the therapist treat exposure, they treat through or understand how to do exposure response prevention therapy? Do they, can they give me examples of that? Are they taking new patients? Okay, let's go.
Yeah.
You kind of got to do the basic education interview, and then get somebody in, because there are many flavors of OCD, like you've both just kind of said, but the therapists are trained, and you're both trained to like understand how to help it. And while people might have their own unique issues, there are themes that just exist throughout. I want to give a shout out to Carrie. Thank you so much for your comment. Not a question, but more like a comment about how therapy has helped her overcome struggles, and acknowledging it's hard for family to encourage therapy because so often the person with OCD feels like nothing will work. So Carrie, thank you so much for sticking with it, and I appreciate your comment. We have a question about, focus more on hoarding. But somebody a family member with hoarding tendencies or hoarding, and they are moving into a new house, and there's like a house full of all their things that kind of need to be taken care of. How should a loved one approach somebody who might, have a hoarding disorder? Because that is definitely something impacting, the entire family.
Yeah, absolutely. Hoarding disorder is can be so challenging, and in terms of diagnosis, you can have hoarding behaviors and compulsions that are under the category of OCD, or you can have hoarding disorder, which is completely separate from OCD. It's not one and the same all the time, but with hoarding disorder, it can be a very challenging thing to overcome, and may require some support from a professional. And usually professionals who can really work with individuals with hoarding, or to declutter their homes, sometimes they're able to come into the home, or maybe virtually go through and be able to help them go through each of their items and help them make decisions regarding how to throw items away. It's when we look at folks who have tendencies to hoard, making it into like creating conceptualizations of like, okay, this person might not have the skills that they need to organize the way that maybe you and I would organize, or to easily make decisions about what's important and what's not. And they might also feel intense emotional attachment to those items. And I think that's like the most important piece that people who don't have tendencies to hoard don't really quite understand. What's the big deal? Just throw it away. It's just trash. And that will feel extremely invalidating to the individual. And then they might become more resistant, more angry. But to really be able to show the person that you're respecting their feelings, respecting their things, and saying, okay, I want you to have the opportunity to really take a look at all of this. And then, you sometimes, you might agree that we have to get rid of some stuff, right? So what's our goal? We have to get rid of our stuff because we're moving to this space. We're not going to fit with all these things. And then to slowly but surely go through those items and allow that person to be able to have that moment, as opposed to being like, that's not important, we're just going to throw it away. But it can get challenging, and that's why I kind of started off this by saying, like, eliciting the support of a professional can really help, especially just allowing the loved one to understand where this person is coming from, why they might be having so much trouble with this. Because again, it can be conflictual, it can be angering and frustrating for all parties involved.
Yeah, certainly. What this topic makes me think is something, and what I would love to get your opinion on. I mean, clearly hoarding is something that impacts the physical space of everyone who's living in that home. And one thing that we know about OCD is it loves to bring the family and it loves to engulf everybody in the issue and become the main center of attention. So, while somebody with OCD might be resisting treatment, how about the loved ones or the other family member, the siblings? What are some ways they can work on not having OCD control their lives? Natasha?
Yeah, we live that day in and day out. And it is important to protect the integrity of the house and the family and not let OCD hijack every element. And that's hard. That can be really hard, especially if it already has done that. Like, how do you pull back systematically and remove those accommodations? And siblings included, you have to talk to the siblings and say, when your brother or sister is going to ask you to do this or say that or target you, let's proactively have a plan. And I've done that in my practice. I do that with my own kids. Is we have a plan and there's some rules. These are OCD's rules, but these are our family rules. And not having, I'm really giving that support to the siblings, even if they have to meet with a therapist alone or have their own therapist for support, because a lot of times they're the ones that are caught in the OCD loop, or they're the target, which is really hard.
Oh yeah. Kind of like we have both experiences where the sibling had to just take the back seat, but also was the exposure, and explaining to your sibling, okay, your sister's going to touch you and scream and run away from you. That's a whole different, another round of emotions to have to deal with. But you are touching on a big topic of how you get OCD. How do individuals extract if OCD is going to really make somebody not want to get treatment themselves? Does that mean the person who doesn't have OCD is stuck or can't move on or can't try to pull back and not accommodate OCD in their lives? Any ideas or suggestions you have for those who might be looking to say, like, okay, if you're not going to get help, I'm going to get help for myself? Jen?
Yeah, I that is what I suggest to family members and loved ones when they do come to me and they say, I've been trying for years and years and years to get my child to go to therapy. And usually it's parents of adult children who will come to me with their concerns. And, I'll say, well, are you getting help? Are you getting support? Because this is a very, very hard way to live. And when you are living in a home with OCD, the way in which it takes over your life can be tremendous, depending on the severity of the OCD. And actually, some families, it has impaired their life so much that they don't even know that it's abnormal anymore. They don't even know that the way that they live their lives is not a way in which a family should be functioning on a day-to-day basis. And so sometimes some family members, they desperately want their loved one with OCD to get treatment, but they don't really always think about, well, what about me? What can I do in this situation? I think that the addiction world has done a really nice job of bringing in parents, family members, spouses, loved ones, having support groups from them, like a really kind of structured sort of way of supporting families. And I do think of things very similarly with OCD as well, that the people who are affected need as much support, and that we need to have those channels for them. And there are ways, especially if they're living in that same home, of being able to say, okay, you're not going to get help, but I am, and I don't have to participate in this anymore. Like if you don't care that you have OCD and you're okay that that you're living with this, okay, but I'm not okay with how it's impacting me. So what can I do to pull back? And like Natasha had said before, it really depends on where it's at, and to be able to systematically pull back can be really challenging. It certainly is going to disrupt the equilibrium of the household, which can be extremely aversive to the family member who is attempting to do this. But at the same time, it's something that's necessary in order for the family member to get their lives back. And what they're doing in turn, I think, is also helping the person with OCD, right? So saying, I'm not going to engage in your compulsions anymore. I'm not going to participate in these rituals. And the loved one can say, well, I'm doing it for me, but actually, really, they're doing it for the person with OCD. They're helping that person by not accommodating them, by not enabling the compulsions and the rituals.
Yeah. I was actually, one of the things you were talking about with dealing with families made it seem like there you might be actually having active sessions. I don't know if this is part of the treatment that Rogers runs, but do you actually sit with the families and work on strategies for them? I mean, practice, how not to accommodate or run through scenarios so that somebody might know how to handle it?
Yes, it's a big part of it for our child and adolescent programming. With our children and adolescents, we have required family sessions because, these things don't happen in a vacuum. The parents have to understand how to understand and approach the kids when they're going through this treatment. They need to know how to support them. The parents sometimes have a real dichotomy between, the parents where maybe the mother accommodates all the time and the father never accommodates. And we really want parents to be on the same page, because if you're not on the same page, that can be very challenging as well in terms of progression of treatment. Of course, whenever anyone comes in, we do an assessment, we develop their hierarchies. And for our children and adolescents, a huge part of that is, where's the accommodation? Who's accommodating? What kind of accommodations are you receiving? And let's work with the parents to start systematically pulling those things back. In our residential programs, if the parents are involved, it's a little bit different, because in our residential programs, the children and the adolescents are removed from the home. So you're in a completely different setting as well. And so the amount of work we might do there will differ in terms of how it looks like from our PHP and IOP. But then over time in that treatment, they do involve the families so that they can prepare the child to go back home, so that they are able to support the child after they've they've basically been in 24 hours, 7 hours a day sort of OCD care or some sort of therapeutic setting. How do we prepare them when they get back home? How do we make sure that the families are ready to support them in their treatment and their recovery?
That's awesome to hear. And I guess, a very, very soundbite message is, if your loved one is not willing to get treatment, there are strategies that you can follow and take to get help for yourself, and, learn how to not accommodate and let OCD take over your life. That's great to hear. We have a question from Anna, who's a trigger for her teenage son and not able to communicate. So how can Anna know if the son is serious and seriously doing his ERP, and a therapist is not, keeping the treatment confidential? So, if you are a trigger for anxiety and OCD as a loved one, how, I don't know, what are some strategies and ideas where you might be able to kind of understand how things are progressing and working, things to look out for, things you might be able to, learn and understand? Natasha?
Yeah, I wonder, she said teenager, so I'm assuming it's still a minor. First of all, I know how hard that must be. I mean, to be the source of the contaminant is just so painful. So I just want to acknowledge that first. But if it's a minor, you should have some communication with the therapist where you can say, how are things going, or what should my role be? I mean, as a parent, I'd want to know, am I supposed to be pulling back my accommodations? He walks into a room, I leave the room, I can't touch his food, like I can't speak to my husband, all these things that normally happen when they live under your roof and you're like the source of the contaminant. are you supposed to be, not doing that? Like there needs to be instruction, I would assume. So, and if there's a reason why their communication can't happen, like you will contaminate therapy or the therapist or, whatever OCD might be communicating, then could another relative be the communicator to talk to the therapist? Because it sounds like there needs to be some communication, because it's like treating an arm without treating the rest of the body. Like you have to really want to work with the whole system.
Very true. And not understanding like how, if you are the trigger, what is being worked on and talked about so that you can, so the person with OCD, you're not the trigger anymore. What are the exposures you should be doing as a family or together to figure out how to dial that back and work through that anxiety. So the suggestion about asking a relative or a loved one or somebody else to be that outreach might be interesting, because if it is the fact that you might contaminate the therapy office, we don't know what OCD's devious devious ways will make somebody think or act. So that's I always learn something here, and hearing about the privacy letters and that kind of permission if somebody's an adult, as well as learning just about the different how to maybe use somebody as an intermediary. Definitely two things that I've learned here. Thanks everyone for joining. If you have a comment or a question about resistance to treatment, please put it in the chat. I've seen a lot of good, affirmative conversations, people who are getting therapy, people who realized they might have, were resistant for a while, but ended up getting it and having good results. So thank you for all those kind of affirming comments, and we appreciate them in the chat. One thing that's can happen, and I've observed from doing different camps and talking to other parents, is OCD, the anxiety can cause rage or anger and outbursts, and that can be really disconcerting, scary for parents and loved ones, and also a potential reason for resistance. If you got to go to therapy and someone explodes on you and is really angry, what are some strategies to deal with when you're having when you have to navigate like a different emotion of anger and rage on top of OCD? Jen?
Yeah, absolutely. And I've worked with a lot of kids with OCD and adolescents with OCD, actually adults with OCD who do have that rage response. It doesn't just end in childhood. And there are kind of going back to some of the things that Natasha was saying, especially when you're working with a child, is, there are the OCD rules and there are the house rules. And, in house rules, we still treat each other with respect. We don't hurt each other, like, especially if a rage attack turns into beating, breaking, things like that. Those rules still apply. And having appropriate contingencies related to that. And saying, okay, and in that moment, so in the moment, there are de-escalation sort of things that can be done without having to give into the OCD. But then after the moment, depending on how that goes, there can be contingencies associated with that. So what with the individual with OCD, I think what's something that's important to remember or to keep in mind is that rage is also associated with shame. That a lot of these kids and folks who have these rage attacks afterwards feel an enormous amount of shame of what they've done and how they've acted and behaved. So first, kind of reminding families, that we want to be able to approach this in a delicate way, and that a lot of times they don't want to be doing this either. So how do we help collaboratively to really be able to give them a plan? So coping ahead, planning ahead of, hey, when you do this, this is how we're going to react and respond. So if you ask me to be part of your ritual, and I'm going to say, hey, I'm not going to do that because that's your OCD. And if you start to scream and yell at me, then I'm going to go to my room and I'm going to close my door. Or it could be if you start to, throw things at me, I'm going to go and I'm going to try to keep myself safe. And I always say that to parents. You always want to think about safety too, especially when you're working with maybe a child who's much larger than you or bigger than you or stronger than you. How do you keep yourself and your family safe? And that needs to be number one priority. But beyond that, it's just really kind of helping them work through. So when we're in this, this is what I'm going to do. Do you think if you did this, it would be helpful? So if would walking away from you be helpful? Would it be better if I led you to your bedroom? Giving them sort of options and being part of that plan in terms of when this happens, these are the steps we're going to go through so that people don't get hurt, and we can try to de-escalate this as much as possible. And then, and it's hard in these moments to see those incremental improvements where, well, he did still scream and shout, but he didn't break anything this time. It's like, okay, well, that might actually be an improvement. So can we reward that? And that's really hard for families too, because they're like, no, I don't want to reward that because we just went through this nightmare of an evening. It's like, yeah, but we have to reward that because that shows that your kid was trying. You were trying not to do that. And so we have to shape that behavior as challenging as it can be.
Yeah, I love that. I think it's so important because I like how you touched on the shame, because often it's such an assault as a parent to have that it is really hard to anchor ourselves and detach ourselves and see it for what it is. And a lot of times it turns inward. It's, I hate myself, I'm a horrible person. And so seeing that progress is really helpful. And I know I've done this with my own son who struggles as I'm listening to him behind the closed door. Like, I hope he doesn't lose it while I'm on this live. But, saying like that only was 10 minutes. And that takes a lot as a parent to go in and circle back and celebrate something when you're exhausted and you're shaky and you're overwhelmed from an outburst, to say, normally they are 20 minutes and things get broken. And this was 10 minutes and nothing got broken. And you went upstairs by yourself. And a lot of times you'll get resistance from your child. No, I was horrible. I did horrible, and it's, it takes a lot, I think, to be neutral and to be able to do that. And maybe you can't do that night. Maybe you need some space and you have to come back the next day. But it is very healing and therapeutic to feel, for that child or teenager to feel like maybe it wasn't as bad and I'm making progress. It really encourages the next time of, shorter and, and building those skills.
Setting up that communication ahead of time and anticipating what's going to happen if it does happen, I think is so important. Also, in celebrating, I don't know if you want to call them wins, but celebrating the progress. If it is, instead of a 20-minute, it was a 10-minute. And you just, both of your comments are just reminding me that, like, OCD, learning how to help OCD or like work somebody through how OCD anxiety is affecting them is like you're unparenting your normal instincts in a lot of ways. And so the idea of saying, like, we're gonna say, hey, that was wonderful. It was a good job that you only screamed for 10 minutes. Last night was a half hour. It's not necessarily celebrating, but it's acknowledging progress, which is so important. And just like your goal is to just build wins as you go throughout this treatment lifestyle.
I think it also is showing the child that it's not black and white. And I think that's super important, because once people get into this mindset of either, I'm successful or I'm not, or I did an exposure or I didn't, that is really, really, really hard to get out of. And we need to be able to show them, like, are you making the effort? If you're making the effort, it's okay if you didn't do it perfectly. You'll never do something perfectly the first time. That is not the expectation at all. But we really have to show them that, and because it's practice, right? You have to really work on it. This is incredibly hard stuff. And to show them it's not black and white, and you are going to have a bad moment, right? That you made a lot of progress, maybe things got a lot better, and then all of a sudden there was one really, really bad situation. That doesn't undo everything that you've done. It just means, okay, well, we know how to do this. Let's get back to our plan. Let's get back to what we were doing. And we know we have a better sense of maybe what works and what doesn't work. But it's not black and white. And I think it's such a great sort of like learning tool or experience for just life as a whole. If nothing is black and white, that we don't always have to go down this one path, that there are many, many, many paths for us to go down, and that regardless of how we go about it, as long as we keep trying, we'll probably get where we need to be able to be, or, in a place where our life feels more valued and more full.
Really, some great advice that we're getting this hour. We have a few more minutes. There's a question just popped in, so I want to get right to it. Thanks, Christine. Her son has just right OCD and needs validation on everything. He's constantly repeats and asking questions, and he's been taking medication and was in therapy with very little results. So, suggestion for somebody who's tried it, taking medication, the therapy isn't working well. Other ideas to try for this family. Maybe one question like how the parents can handle it. Christine could handle it, as well as like some ideas for her son to try another shot. Natasha.
Yeah, the first thing I'd want to do is make sure he really understands how just right OCD is showing up for him and how he's feeding it. Because I think often we think, well, they've been in therapy, they've had treatment. And, I've worked with kids where they still didn't get it. They didn't really fully get it. They're really so immersed in the lie of OCD that they're not, you have to detangle that first. And then communicate as a parent. When I repeat, and I'm constantly repeating for you, or for OCD rather, I'm growing your OCD and I love you and I can't control your part of this puzzle, but I can control my piece of the puzzle. And I don't want to make your mental health worse. And I don't want to feed it. And so I would probably look at pulling back those accommodations parentally and communicating from now on when you ask me, and maybe look into the SPACE program, Ellie Leibowitz's SPACE program on how to systematically pull back those accommodations. But I would have a proactive plan of when you ask me this from now on, and maybe just one small thing to start with, I am not going to repeat myself because I love you and because I'll be growing your OCD, which is hard. I totally get it. Really, really hard.
I would also, some of the things that we kind of think about also is dose, and dose of treatment. And I think about, and here at Rogers, we talk about it as well, is that did you get the right dose of treatment? So is it, you may be getting the right treatment, but is it the right amount of that treatment? The idea being, it's kind of the analogy is like an antibiotics, right? Like your doctor tells you to take it for 10 days, you stop after 4 and the infection comes back. Like, okay, you didn't take, you were on the right treatment, but you didn't do it for enough or for long enough. And so that is something that I think is important to look at too. So if someone's not responding to outpatient therapy, well, there's a lot of other options. There are, higher levels of care. Do they need an intensive outpatient option? Do they need something even more than that to be able to help them on their treatment journey? And also with medications, and this is more of your traditional kind of idea of dose. It's like, are they on the right dose? They might be on the right medication, but as we know, all the research shows us is that with OCD treatment, medications, the doses go up. They go higher than, than what, sometimes some doctors are normally used to prescribing. And that is, and unless they're working with somebody who really knows and understands OCD, the doctor might not really be able to recognize that. They might be like, well, you're on the right meds. I don't really understand why this isn't working. And we see that a lot. We see that a lot with patients who come to Rogers. We look at their medication history and we say, hey, you're on the right thing, but we gotta put you at the right dose, because all the research has really shown us that we got to get to this point before it really becomes effective for OCD. So I think there's a lot of different ways to kind of look at it when we talk about dosing, whether it's purely behavioral, therapeutically, or if it's from a pharmacological perspective as well.
Some great tips there. Christine, hopefully that was helpful. Also, I just recommend if I'm sure you have done this. If not, doing some research on your own, ideas of different treatments for just right, how you might be able to communicate, different ways to talk through the need to get back into therapy and work on either a hierarchy or, take another shot at trying the therapy and working together as a family on it. And then also making sure that you are caring for yourself, as well as, working on ways to not accommodate, dial back on, like when Natasha was saying, like, I don't want to keep answering you because I'm feeding your OCD and I'm doing it. I know it might hurt you because you might think I'm not doing it because I don't love you, but I am doing this because I think it will help you. So important. I hope everyone found the last hour helpful. We were talking about resisting treatment and some options for caregivers and families and how to help their loved ones with OCD. Natasha and Jen, before we close out, I would love you to just share, maybe where people can find you after this if they want to reach out or learn more about you. Jen?
You can, should I give it like an email address or
like if, or like a, social media or, like maybe the website for Rogers to learn more.
Yeah. You can just Google me at Jennifer Park at Rogers Behavioral Health. Unfortunately, I'm not that much on social media right now.
Cool.
That's
Thank
nice.
you.
Yeah, people can find me at atparentingsurvival.com.
Awesome. Thank you so much. Chris Bear, you can find the film at ocdkidsmovie.com. There's also resources which link out to a lot of the work that Natasha has done. And just want to give a shout out to Rogers because 3 of the kids in the film also were treated there. And so I know how beneficial that program could be. Thank you so much for joining us today. I just want to read some closing announcements. Just a reminder, the IOCDF would love to hear from you. So please take our live stream survey. Tell us what you'd like to see more of on this platform, different topics or different subjects. The feedback can be given at iocdf.org/livestream survey. One word, live stream survey. So iocdf.org/live stream survey. You can also subscribe to the YouTube channel where you'll be able to see everything and get notified on every live stream that they do. I think there's pretty much somebody on every day and some different times of the day. Be sure to follow the IOCDF on Facebook, Threads, and Instagram, TikTok, on all the socials. And this live stream is one of many. So if you want to see the entire schedule and whatever's coming up in the future, just go to iocdf.org/live streams. You can see everything that's going to be on the schedule the rest of February, as well as beyond that. You can also view recordings of the past live streams, as well as watch our host answer pre-submitted questions, the quote-unquote IOCD mailbag. That's on the IOCDF's YouTube channel, youtube.com/IOCDF. And you can like and subscribe on socials, and that way you'll get notified on all the platforms of what's going on, whether it's upcoming events, news and information, important tips, different topics or live streams. You can get it all there. The IOCDF is trying to cover a lot of bases and help everyone out there find community and also the resources, which are so important. And you can also lastly sign up for the IOCDF news and updates at iocdf.org/sign-up. And if you want to support the IOCDF, there's a donate button on their website. Every dollar helps. Every dollar helps fund these programs and support wonderful live events and all the different things that the IOCDF is trying to do. And lastly, but not least, thank you so much for Jack MHA for their support, and Natasha and Jennifer for joining us today. What else did I miss? I think I made the donor. Yes, donor. If you want to donate, iocdf.org/donate is the website. Thank you so much. We'll be back next month with another topic. Till then, we hope that this was helpful for you today, and we hope to see you next month. Have a good evening, or good morning, or good day.